Showing up online. Good morning, everyone. Welcome to New Hampshire Insurance Department's annual hearing on premium and the insurance market. I'm Chris Nicolopoulos, Commissioner of Insurance, and this is an opportunity to present the department's findings from data submitted to the department and create a public forum and discuss related issues. It's been an interesting year. I think this is the third opportunity I've had to present our annual hearing, but the first where we've got to do it live. And so I think it's an amazing opportunity for 30 of us to be here again in person, but also to have adopted the technology to allow more than 40 other people to be listening and participating online. These new hybrid tools allow us to reach more people, and I think that's a tremendous opportunity for us. I'm excited today to hear Gorman Actuarial's presentation on our healthcare data. I'm especially interested to see how the 1332 waiver that we adopted 2 years ago is continuing to impact our marketplace and our premium. And I'm looking to see how it's going to impact next year. As you all know, New Hampshire Insurance Department for more than a decade has been working on price transparency, whether through our health costs website, by updating that data through our annual reviews. You'll find that this year our updates included 32 new procedure codes, also a high cost prescription drug dashboard. Our work is in conjunction with what the federal government's been doing on requiring price transparency at the hospital level. I think we can work together to ensure that consumers appreciate that they can play a role in controlling health costs by making good consumer decisions as it relates to their healthcare decisions. I'd like to take a second and recognize some of the staff from the department that are here. We have several new people in new roles at the department. Today is an awesome opportunity for you to get to put a face with the name. And I encourage you at the break to reach out to people from the department that you haven't had a chance to meet in person yet and introduce yourselves. In no particular order, based on my chicken scratch here, we have Roni Carnes, who's one of our PLAs in our health side. Michelle Heaton, another product line attorney, PLA from our team. We've got Dr. Jason Aziz. He's the Director of Health Economics for the department. He's a new hire since last year. We have Jason Dexter, our Life and Health Director, who's been promoted since last year. Welcome, Jason. Andrew Demers, who's our PIO, our Public Information Officer. Andrew is the first line of defense for getting out all that great information that the department does. I'm sure you've noticed over the last couple of years, we've been increasing our use of press releases, the bulletins to get information out, consumer advisories. Andrew's responsible for most of that. We have DJ Betancourt, our Deputy Commissioner. Sandra Barlow, who's not in this room, but is kind of the dean of the executive team at the insurance department. Really, she makes it all run. We got Maureen Belanger, who's the chief of our market regulation. I think that's the whole team. If not, I apologize in advance. I also want to recognize a couple of contractors of ours from Gorman Actuarial, Jenn Smagula and Don Gorman. I think that's it for my notes. Jason Dexter. I'd like to introduce everyone to Jason Dexter. He'll take from here.
Thank you, Chris. Thank you all for coming. My name is Jason Dexter. I'm the Director of Life and Health. I have been in this role for probably 5 months, so I think the beginning of the planning of this particular meeting. I'm going to do the logistics portion for us today before we get to the substance. It's a little housekeeping stuff. A few things for you. It will be recorded today, and we will be posting it on YouTube afterwards. It's a standard question we get. Everybody will be muted, so if you're participating online, you'll be automatically muted, so we can avoid issues there. We are on Teams. The Teams chat feature will be monitored throughout. When Gorman Actuarial is speaking, Don Gorman's going to monitor the Teams chat feature, and when DJ is moderating the panel discussion, Andrew's going to monitor the Teams chat. So we're going to start today with the Gorman presentation. Jenn Smagula will be presenting. If you walked in, we had an agenda here on the back with QR codes for some of the materials we have. If you want to pull that up, We have Wi-Fi information right behind us if you need that information. And then after Jen's done speaking, there will be a Q&A for her presentation. We'll take a short break afterwards. Refreshments downstairs. If you need restrooms, you can go out this door and walk that away, or if you're downstairs, same direction. Okay. After the break, we'll reassemble, and Deputy Commissioner DJ Bencourt is going to take over for a panel discussion with some folks we have here today. Appreciate everybody coming to join that conversation. And we will end with the official public comment period. With that, I can turn it over to Jen.
I'm Jenn Smagula. I'm a healthcare actuary working with Gorman Actuarial. I'm joined here today in person with my colleague, Don Gorman, and virtually I'm joined with our colleagues, Linda Keene and Emma Rourke. So I'm going to take you through this presentation on the key findings from our 2021 preliminary report on New Hampshire's healthcare premium and claim cost drivers. So the goal of the report and presentation is to examine health insurer premium and claim costs and the factors contributing to changes in those costs. So this year's focus is on 2021, but I'll also be presenting some of the available information from early 2022. The uninsured rate in New Hampshire, which is shown in red, decreased from 6.3% in 2019 to 5.1% in 2021. Now, at the same time, the United States average uninsured rate, which is shown in black, also decreased slightly from 9.2% to 8.6%. And this chart also shows the other New England states. So when comparing New Hampshire to other New England states, their uninsured rate is slightly above the median in 2021, with Massachusetts having the lowest uninsured rate at 2.5% and Maine having the highest uninsured rate at 5.7%. This slide gives an overview on where New Hampshire residents received their health insurance in 2021 based on information collected from the American Community Survey. So as we reviewed in the previous slide, the uninsured rate in New Hampshire is around 5%, which is shown in orange. Of the 1,373,000 New Hampshire residents, this translates to around 70,500 residents not having health insurance. Approximately 61.5% of residents in New Hampshire received their health insurance through the private commercial insurance market. So either through their employer, which is shown in blue, or by purchasing coverage on their own, which is shown in purple. Now, after the employer coverage category, Medicare is the next largest coverage category at 15% in red, followed by Medicaid in green at 10%. These next couple slides compare the New Hampshire average premium to the average premium from other New England states and to the US average. So this first slide looks at the individual market using publicly available information from the CMS risk adjustment reports. Average premiums in the individual market decreased about 15% in 2021. So this decrease is primarily due to the Section 1332 waiver state-based reinsurance program, which began on January 1st of 2021. Now in the United States, the average shown on that red line, the change in average premium was fairly flat from 2019 to 2020 and into 2021. When comparing New Hampshire to the average of New England being the green line, New Hampshire's individual market premiums of $451 are about 23% lower than the New England average of $587. So note that Vermont and Massachusetts are not included in the New England average as they have merged markets in 2021. New Hampshire's actuarial value, which measures benefit richness, is consistent with the New England average, while the New Hampshire risk scores, which measures morbidity, are slightly lower than the New England average. So this chart takes the same data used in the previous slide and shows New Hampshire's average premium in the individual market, which is shown in red, compared to other states. So as shown, New Hampshire's 2021 average premium ranks the 5th lowest across the country in the individual market. So this is an improvement from last year when New Hampshire ranked as the 15th lowest. Now this slide looks at the small group market using the same publicly available data from the CMS risk adjustment reports. New Hampshire's small group market premium, which are the blue bars, remained close to the United States average in 2021, with the US being the red line. Average premiums increased about 4% in New Hampshire and in the US in 2021 compared to 2020. The average premium in New England, the green line, increased about 5% during this same time. New Hampshire premium continued to be lower than the average in New England, and they were about 9% lower in 2021. Now, New Hampshire's risk scores are lower in the small group market, which will drive some of the premium differences in New Hampshire compared to the New England average. Now, in the small group market as shown here, New Hampshire's 2021 average premium ranked 19th highest in the country, and this is consistent with where they ranked last year. So this slide compares large group average single premiums in New Hampshire to the United States average and to other New England states. CMS risk adjustment does not apply to the large group market, so we don't have that same data available to us that we used in the previous slides. So here we're using data from the Medical Expenditure Panel Data Survey, or MEPS. The United States average is shown in black and New Hampshire is shown in red. So the other New England states are shown in the different colors. So this shows that in the large group market, New Hampshire is consistently higher than the US average premium. And when compared to other New England states, New Hampshire's relative position has fluctuated over time. In 2021, New Hampshire has among the highest premiums in New England, along with Vermont, Rhode Island, and Massachusetts. Now, New Hampshire does have the 2nd highest average age and the 6th highest median income by state across the US per the 2021 US Census information. So these factors most likely contribute to higher average premiums in New Hampshire. And note that the premiums here include both the employer and the employee portion. So moving on to coverage shifts. So here we're looking at health insurance enrollment by market segment, by insurer, and overall to look at shifts in coverage. So this first slide gives an overview of the New Hampshire Citus commercial insurance market from 2018 to 2021. Now, by New Hampshire Citus, we mean that New Hampshire has jurisdiction over the policy, which in turn typically means that the employer is headquartered in New Hampshire, but these aren't necessarily all New Hampshire residents. And by commercial, we mean people who purchase insurance on their own or receive coverage through a New Hampshire employer. On the left-hand side, the gray bar shows the proportion of membership within each commercial market segment in 2021. So similar to prior years, the majority, or approximately 89% of commercial coverage was purchased through employer-sponsored insurance. So this consists of the small group market, the large group fully insured market, and the large group self-insured market. And note that over half of the commercial market, or 54.6%, are enrolled with large self-insured employers. Now, the right-hand side in color shows the average enrollment by market segment for the past 4 calendar years. So looking at the top, starting with the individual market, the number of individual members increased significantly from 2020 to 2021 by about 5,600 enrollees, most likely due in large part to the new state-based reinsurance program that started in 2021. Now, there were some other changes that happened in 2021 that we'll discuss further in some subsequent slides. The small group market continued to experience some decreases over the past couple years. The self-insured segment on the bottom experienced a decrease of enrollment from 2020 to 2021 of about 7,900 enrollees, while the large group fully insured segment was fairly consistent from 2020 to 2021. So overall, membership is fairly stable when you look at it in total from 2020 to 2021, and New Hampshire is currently at approximately 493,000 enrollees in the commercial market. So this slide drills a little bit more into the small group market membership from 2019 to 2021 by insurer. So in prior years, we had seen that the Tufts Health Freedom Plan, which is shown in purple, had increased their market share significantly. But looking at 2019 and into 2021, we see that their market share has now decreased from 21% in 2019 to 15% in 2021. Now note that as of January 1st, 2021, United Healthcare owns the Tufts Health Freedom Plan. During the same time, Anthem Matthew Thornton, which is shown in blue, has increased their market share from 40 to 47%, and Harvard Pilgrim, shown in red, has been fairly consistent. Now we're showing similar information for the individual market. So in the individual market, Ambetter, which is shown in orange, has continued to increase their market share, having very little presence in this segment when you look back to 2017, but growing considerably. They were 22% in 2019 and grown further to 38% in 2021. While Anthem, at the same time, Anthem Matthew Thornton's market share has fluctuated over the past couple years. It was at 68% in 2019, and that's decreased to 49% in 2021. And Harvard Pilgrim, they've remained fairly stable, but they have grown a bit from 2019 into 2021. So up to this point, we've been looking at enrollment data in 2021, but now this slide compares fully insured membership as of April 2021 into April of 2022. So overall enrollment was fairly stable from 2021 to 2022, but we do see that there were increases in the individual market offset by decreases in the two group markets. So here we see an increase of approximately 6,000 enrollees in the individual market from April of 2021 to April of 2022. So the individual market, as we mentioned, or as I mentioned earlier, experienced several changes in 2021. So first, as we've already discussed, New Hampshire's state-based reinsurance program started on 1/1/2021, helping to lower premiums in the individual market. Secondly, the American Rescue Plan Act of 2021, or ARPA, expanded eligibility for premium subsidies and increased the financial assistance to those who already qualified for subsidies. And lastly, there was a special enrollment period in 2021 that extended the deadline for enrollment to August of that year. So all of these factors most likely contributed to the enrollment increases in the individual market in 2021 and then even further into 2022. The large group insured market experienced a decrease of approximately 4,000 enrollees during this time frame, so they're shown in teal, while the small group market also experienced a small decrease of about 1,000 enrollees, shown in purple. So now this slide takes a more long-term view of enrollment for the individual and small group market. So through the annual hearing data collection process, membership is now collected as of April, July, and December of each year. Each dot on this chart represents a data point, and the small group market is shown in red, and the individual market is shown in blue. So between April 2018 and July of 2022, small group enrollment declined about 10%, losing 7,000 enrollees during this time frame. Now, the individual market membership in blue is more volatile. So what we see is that there are typically decreases in membership from the beginning of the year into the end of the calendar year, except in 2021. So this is most likely due to both the expanded ARPA subsidies that took place into mid-2021 and the extended enrollment period in 2021. Now, as we saw in the previous slide, there is a significant increase in enrollment into 2021 and 2022, with the individual market currently at close to about 60,000 enrollees as of July 2022, compared to where they were back in April of 2018 at 53,000. Now this slide goes one step further and takes the individual market and breaks it into 4 pieces. So the pieces being the non-exchange market in red. So this includes enrollees in ACA plans who are purchasing them off exchange, but it also includes the grandfathered and transitional enrollees, which represent about 3,000 folks in 2022. The purple line are the exchange enrollees above 250% of the federal poverty level who are eligible for advanced premium tax credits or APTC. The green line are the exchange enrollees between 138 and 250 of FPL who are eligible for both the advanced premium tax credits and the cost sharing reduction subsidies or CSR. And lastly, the blue line are the exchange enrollees who are not receiving any kind of subsidies. So again, New Hampshire introduced their state-based reinsurance program on 1/1/2021, which significantly lowered premiums in that segment. Between April 2020 and April of 2022, the non-exchange membership in red increased by about 1,900 members, and the exchange non-subsidized membership in blue increased about 4,100 members for a total of 6,000 enrollees. So this is the group of people who are not receiving any subsidies, so they really saw firsthand the benefit of the reinsurance program. Now, these enrollment changes were most likely, again, due to the benefit of the reinsurance program. In 2021, ARPA expanded eligibility for premium subsidies for those over 400% of the federal poverty level for 2021 and 2022. Now, the Inflation Reduction Act has extended those subsidies into 2023, 2024, and 2025. New Hampshire experienced an increase in the subsidized exchange population with over 250% of the FPL, which is in purple, growing from 13,500 enrollees as of April 2020 to 16,500 enrollees as of April 2022. So I think this slide is just interesting because it really shows how the different policies implemented in 2021 and into 2022 is directly impacting enrollment. Now, consistent with the individual and small group markets shown in the previous slide, this slide shows the large group fully insured segment in red and the self-insured segment in blue in their membership from this same time period, April 18 to July of 2022. The self-insured segment did increase slightly into 2020, but then recently they've decreased by about 5% or 13,000 enrollees from April 2020 to July of 2022. Now, one insurer who experienced some losses in this segment cited furloughs, layoffs, and leaves of absences due to COVID, along with the loss of some larger employer groups as contributors to the decline. The large group fully insured segment has experienced slight but steady decreases over the same time period. They've lost about 6% of their enrollment, or 8,000 enrollees. This table compares New Hampshire commercial situs enrollment and the New Hampshire Medicaid enrollment from December 18 to July of 2022. So again, New Hampshire situs enrollment means these are employers who are based in New Hampshire, but their employees may live outside of New Hampshire. Medicaid enrollment is based on being a resident of New Hampshire. So total commercial enrollment, which is a combination of the 4 segments we've been talking about, the individual market, small group, large group insured, and then the self-insured. And we can see that total commercial enrollment has decreased slightly in 2018 into 2021, but then it's been fairly stable from 2021 into 2022. The Medicaid enrollment is coming from the New Hampshire HHS website, and these data show that enrollment started increasing in April 2020 and has continued to increase into July of 2022. And in total, Medicaid enrollment's grown by about 55,000 enrollees during this time frame. Now, during the COVID public health emergency, Medicaid redetermination, which is the process that the states use to ensure Medicaid enrollees continue to be eligible for Medicaid coverage, was paused. So we're only seeing the growth in the Medicaid program and not any of the disenrollments that would typically happen during a time when there is no public health emergency. So this slide, we're going to focus on the individual market exchange membership, and we're looking at their metal levels in 2020, 2021, and 2022. So the metal level represents a plan's actuarial value or benefit richness. So generally speaking, bronze plans have lower premiums and higher cost sharing, while silver and gold plans have higher premiums and lower cost sharing. So for members on the individual market exchange, we're seeing that there was a shift away from bronze plans to richer silver plans and to gold plans. From 2021 to 2022, the percentage of enrollees in silver plans, excluding those eligible for CSR, and the gold plans have each increased about 3 percentage points. So the gray bars, the 15% to the 18%, and the yellow bars, the 10% to the 13%. So this is coupled with decreases in the bronze plans in 2022. So this is most likely due in part to, again, the reinsurance program that started in 2021, where premium reductions allowed some enrollees who may have otherwise chosen less rich bronze plans to afford the richer silver and gold plans. So now we're going to transition and look at membership by type of provider risk contract by looking at the percentage of fully insured New Hampshire members with a provider in a risk contract from 2018 to 2021. So we looked at this 2 ways. We looked at membership in upside and downside risk contracts, which is shown in red, and membership in upside only risk contracts shown in blue. So a provider contract with upside and downside risk is defined as a contract where the provider will share in any budget surplus or deficit with the insurer. So an example of this would be a capitation arrangement. Now, upside only risk contracts are where the providers may share in any budget surplus, but they're not at risk for any portion of a deficit. An example of this is a shared savings program. Within the fully insured markets, the percentage of members in risk contracts with both upside and downside, which is shown in red, has bounced around a little bit, but it's currently at 23% in 2021, while the membership in upside only contracts blue has decreased in the most recent months to 18%, or the most recent years to 18%. Now, when you look at this combined, the two bars combined, about 41% of members have or with a provider in a contract that has some type of risk in 2021. This is a decrease of what we saw when you look back at 2018, where about 50% of the membership was in some type of risk contract. Now, not shown here, but we show it in the report, we also look at membership in risk contract in the self-insured segment. So there we see the percentage of members in risk contracts in both upside and downside. That has increased slightly, and they're currently at 21% in 2021, while the membership with upside only has decreased, and that's currently at 27%. 2 of the 5 major insurers in New Hampshire reported membership in upside and downside risk contracts, and 3 out of the 5 major insurers in New Hampshire reported membership in upside only contracts. So now we're moving on to looking at premiums and cost sharing and what's going on with those numbers. So this slide gives a picture of what happened to New Hampshire premiums the last 3 years. So these premiums include both the employer and employee portion in the group market, and they're prior to any subsidies in the individual market. The average fully insured premium, PMPM, in New Hampshire decreased 0.6% in 2021. Now, the individual market experienced an approximate 14% decrease due, again, in large part to the state-based reinsurance program that started in 2021. The small group and large group market premiums increased 3.4% and 4.1% respectively. The small group and large group market premium increases that we see this year are higher than what we saw the prior year. Now, average premiums in the individual market are now lower than what we're seeing the average in the small group market. So the 452 in the individual market versus the 548 in the small group market. Based on the 2021 Employer Benefits Survey from the Kaiser Family Foundation and the Health Research and Education Trust, and 2021 average premiums in the employer market across the country increased 4% for both single and family coverage. So the New Hampshire large group changes we see are on par with that, and the small group changes we're seeing are slightly lower than that. And when we look back in time, the premium trends that we're seeing this year are in the mid to low side of what we've seen over the past couple of years. So when we look back at 17, 18, and 19, premium trends in the group markets were in the 3 to 6% range. Now we're looking at average single in-network deductibles within the New Hampshire commercial market, which is one of the key components of cost sharing. On the left-hand side, we have the individual CSR population. So these CSR subsidies allow individuals to have lower deductibles, lower co-pays, and lower co-insurance while still paying fairly low premiums. These members have some of the lowest average deductibles at about $976 in 2021. So this is much lower than the deductibles for the non-CSR individual market population. The individual non-CSR average deductible is about 5 times greater than the CSR deductible. So the $4,088.70 versus the $976. And because there really hasn't been much change, when you look at each of these segments from 2020 to 2021, we really don't see much change in the average deductible levels, which is saying that because premium increases are fairly low, that members were not forced into higher deductible plans in this year. When comparing the individual non-CSR to the group segments, the individual non-CSR deductibles are also higher than the group markets. They're approximately 40 to 50% higher than what we're seeing in the group markets, and almost 5 times higher than what we see in the self-insured segment. So now we're looking at overall average cost sharing in the New Hampshire commercial markets. So the bars represent cost sharing PMPMs, and the boxes across the top represent cost sharing as a percentage of total allowed cost. Member cost sharing include the costs paid by members either in the forms of deductibles, co-payments, or co-insurance. In 2021, cost sharing PMPMs increased in all segments compared to 2020. Now, cost sharing in 2020 was lower due to members utilizing less services and a change in the mix of services due to the impact of the COVID-19 pandemic. Another contributory factor is that in 2020, some services like COVID testing and other COVID-related items had their cost sharing waived in 2020. On the left-hand side, again, we have the individual CSR population. So this lower income population, they're paying some of the lowest amounts in cost sharing at about $70 PMPM, or 12.5% of their total allowed costs. Then we have the individual non-CSR enrollees who are paying the highest in cost sharing at about 118 PMPM, and that represents about 26% of total cost. And on the right-hand side, we have the large group self-insured segment who continue to pay the lowest cost sharing amounts at about $52 PMPM. So here we're trying to pull together all the information from the past couple slides to show the relationship between premium and benefit richness in both 2020 and 2021. The paid to allowed claims ratio is on the Y, or the vertical axis, and that's an indicator of the richness of a health insurance plan's benefits. The higher the ratio, the more rich the benefits and the less the members are paying out of pocket themselves. The X-axis, or the horizontal axis, is the average premium PMPM. Each bubble in this chart represents a market segment. So this chart maps each segment's benefit richness, or that paid to allowed ratio, with their premiums. The shaded circles represent the results from 2020, and the solid colored circles represent the results from 2021. Enrollees in the individual market who received cost sharing reduction subsidies, indicated by the green bubbles, had the richest benefits in the market because they have the highest paid to allowed ratios, and they're in the upper half of the chart. By contrast, the enrollees within the individual market who do not receive CSRs, or the individual non-CSR population, have the least rich benefits in the market because they're in the bottom half. So when you look left to right, looking at the individual non-CSR small group and then into large group, this generally shows as benefit richness increases, the premiums are going to increase as well. So the premiums shown in all the previous slides are before any premium tax credit subsidies are accounted for. So this slide shows an illustrative example of what a 40-year-old non-smoker single policy holder in New Hampshire would pay for the second lowest cost silver plan and the median bronze plan in 2022 at various income levels, once you take into the account these subsidies under ARPA. So as explained previously, ARPA increased the financial assistance to those who already qualified for subsidies, so those at or below 400% FPL, and they expanded eligibility for the premium subsidies above 400% of FPL. $309 is the full premium per member per month for the second lowest cost silver plan in 2022 for a 40-year-old. And $290 is the full premium for the median bronze plan in 2022 for a 40-year-old. So while ARPA does provide subsidies for incomes over 400% of FPL, the subsidies only come into effect after the enrollee is paying 8.5% of their income towards health insurance. So in this example, 8.5% of an enrollee's income is higher than the actual premium for the second lowest cost silver or the median bronze, so there's no subsidies provided. They're paying the full premium once you're over 400% of FPL. But for older individuals, 8.5% of the income may be lower than the actual premium rate, and that's where the subsidies would kick in. So it really depends on your income level and your age. Now at the far left, we're showing members with FPL between 133% and 250% of FPL. So in those cases, those members are paying anywhere from $0 to $54 per member per month for the median bronze plan. And for the second lowest cost silver, they're paying anywhere from $0 to $72 per month. Now those enrollees below 250 are also going to receive the benefit of those CSR subsidies we talked about, which increases the richness of their benefit levels or lowers cost sharing. Now, prior to the passage of ARPA, enrollees below 400% were still receiving subsidies, but those subsidies have increased as a result of the ARPA provisions. Okay, so everything we've been looking at up to this point was related to premiums and cost sharing. So those are the costs that fully insured employers or consumers incur directly. So now we're going to turn our attention to the claims and utilization, which is the experience that ultimately feed into the premium development for the insured segments. Trends in all market segments were negative from 2019 to 2020 due to the low utilization from the impact of COVID-19 in 2020. Now in 2021, the claim levels have all increased and annual trends are significantly higher than what we've seen in past years. So for example, the overall trend from 2020 to 2021 was 11% in the insured markets. So that's the 502 to the 558. And it was also around 11% in the self-insured market, so the 522 to the 579. So knowing that the 2020 year was an anomaly due to COVID, we also wanted to focus on the 2-year annualized trends from 2019 to 2021. So more of an average annual trend from 2019 to 2021. And that number is 3.2% in the fully insured segment and 1.5% in the self-insured segment. So these trends are on the low side of what we've seen when we look back at annual trends from 17, 18, and 19, where annual trends in the group markets were in the 4 to 6% range. So some insurers have pointed to the fact that services like primary care visits and emergency department visits had not returned to pre-COVID levels at the beginning of 2021, keeping overall calendar year costs in 2021 lower than they otherwise would have been. But then this is offset by some of the increased costs due to COVID-19, the testing, the vaccine administration, and COVID-19 treatment that occurred in 2021. So the impact of these items really varied by insurer. So for example, New Hampshire insurers reported anywhere from 2 to 4% of their total allowed costs being spent on COVID-19 treatment in 2021. This chart takes the combined annual small group and large group fully insured trends from the previous slide and breaks it into 2 components. So utilization and unit cost and mix. Utilization is a reflection of the number of services provided, and unit cost and mix is a combination of the change in the unit price of specific services or the change in the mix of those services or the change in the mix of providers being used. So the utilization trend we saw in 2019, the 1.9%, that was fairly consistent with what we had been seeing in prior years, prior to COVID. And then in 2020, of course, we saw that big negative trend as a result of the pandemic that year. And the cost and mix trends were also lower in 2020 that we had seen in previous years. Now that we're in 2021, the utilization trends have moved in the complete opposite direction. They're at 14.4%. So this really just shows how the impact of COVID has caused very dramatic changes in trend. As part of the annual hearing data collection process, insurers provide average unit price changes or payment rate changes at the major service category level for the current year and then also project for the projection year. So this chart is an aggregation of that data for inpatient and outpatient facility combined, so that's shown in blue, and then for professional services shown in red for the past couple years. So this is showing that across all reporting insurers in New Hampshire, average payment rates increase from 2019 into 2020 and again into 2021. But then that overall payment rate changes are expected to decrease into 2022. So keep in mind this information represents a mix across all of the providers and insurers. So there will be some insurers and providers who are expected to receive higher increases, but this is offset by those providers and insurers reporting lower increases. Now this slide shows total PMPM trends by service category for fee-for-service claims for the group markets. The percentages in the parentheses next to each service category label shows the percentage of that service category, what it represents out of total spend. All medical fee-for-service categories in 2021 experienced double-digit trend increases due to the low utilization levels that occurred in 2021 as a result of COVID. Now, pharmacy trends were also in the double digits, driven by higher utilization and higher cost and mix. Now, there are additional non-fee-for-service costs that are not included in this chart, but are included in the totals from the previous slide. These non-fee-for-service claims include things like for capitated services for behavioral health, as an example, or any risk-sharing payments with providers. Non-fee-for-service costs decreased from $21 PMPM in 2020 to $5 PMPM in 2021. And that change is largely due to changes in provider risk-sharing payments that occurred. So now we're drilling more into pharmacy trends. The bars on the left-hand side represent pharmacy costs covered under the pharmacy benefit, or sometimes referred to as traditional pharmacy spend. The percentages in the parentheses next to each of those pharmacy category labels show the percentage of pharmacy spend that each category represents. So pharmacy trend in this group market in 2021 was around 10% or 9.6%. So this comes after a year of negative trend, the negative 4.2%. So generally speaking, COVID-19 was not expected to impact pharmacy costs like it did medical costs. Insurers indicated that the reductions in pharmacy costs that we saw in 2020 are actually due to changes with pharmacy benefit managers that happened with a couple of the insurers that year. So changes with their PBMs and or changes with the rebate contract that just happened to take place in 2020. Now back to looking at 2021, where pharmacy costs increased by that roughly 10%. So this is higher than the trends we've seen the past couple years prior to COVID, where pharmacy trends were in the 2 to 6% range. Specialty pharmacy trends have increased 7.8% in 2020, and then that jumped up to 14.3% in 2020. And so they've really continued to significantly outpace trends for the generic non-specialty and the brand non-specialty. In addition, specialty drugs or specialty pharmacy now comprise the largest portion of traditional pharmacy spend. When we look back in 2019, specialty pharmacy contributed about 47% of total traditional pharmacy spend, and that's now at 55% in 2021. The right-hand side of the chart shows pharmacy drug PMPM costs covered under the medical benefit. So this includes prescription drugs that are administered at a physician's office or in a hospital setting. And so in many cases, these are high cost injectables. So those trends have actually stayed lower in 2021. They were at minus 0.8% compared to the prior year of 3.8%. When you take the pharmacy under the medical benefit, you combine it with the specialty, and you look at what percentage that represents of all these costs, the specialty pharmacy plus those pharmacy under the medical benefit represent 69% of these total pharmacy costs, whether they're coming through the pharmacy benefit or the medical benefit. So throughout this report, the pharmacy information is presented net of prescription drug rebates. Rebates are the amounts which are paid to insurers or the PBMs from drug manufacturers, reducing total pharmacy costs. Given the changes in PBMs and the new rebate contracts cited by some insurers in 2020, prescription drug rebates have grown. They grew considerably in 2020, and this has continued into 2021. In 2021, pharmacy trends, gross of rebates, or before you take into account rebates, increased at 14%, and this compares to the 9.6% once you account for these pharmacy rebates. So when you look at the overall rebate PMPMs in the group markets, they increased from $25 PMPM in 2020 to $33 PMPM in 2021, which is a 32% increase. Now, about 54% of those rebates in 2021 are for specialty drugs. So this is an increase of what we saw when we look back at 2019, where 42% of the rebates were for specialty drugs. Insurers were also asked last year and this year to start reporting on primary care PMPM spending by market segment for 2019 through 2021. Now, the NHID did not specifically define primary care for the insurers, but each insurer provided their definition of primary care, which generally is based on the provider type and included providers such as general practice, family practice, internal medicine, pediatrics, and geriatric medicine physicians. In each market segment and for each insurer, there was a decrease in primary care PMPM spend from 2019 to 2020 due to the impact of COVID-19. But when we look from 2020 to 2021, we can see that significant increase in primary care PMPM. On a percentage of total allowed claims, primary care spending represents about 6% of total spend in 2021. Now, several states, including Rhode Island, Delaware, and Massachusetts, now have initiatives in place to increase primary care spending or to do more to measure and report on primary care spending. The last two slides in this section present some utilization data by market segment for two key utilization metrics: inpatient admissions and emergency department usage. Inpatient admissions increased in each of the fully insured market segments from 2020 to 2021, and we saw the largest increase in the small group market at 17.8%. But when you look at the overall inpatient admission levels in 2021 compared to 2019, so in this case, the 51.1 in 2021 to the 53.3 in 2019, we see that they're actually lower across the whole market. And when you look at by segment, the levels are lower in each of the segments except for the small group market. Similar to inpatient admissions, when you look at emergency department visits, all market segments experienced trend increases in emergency department visits from 2020 to 2021. And again, the largest increase occurred in the small group market. But when you look at the levels in 2021 versus 2019, again, the emergency department visits are not at the same levels they were back in 2019. So in total, in 2021, we see emergency department visits per 1,000 running at 161.1 in 2021. And back in 2019, they were running at 166.7. So while they have jumped back up again in 2021, they're still below the levels they were in 2019. Okay, this last section shows some medical loss ratio information and risk adjustment information for each of the fully insured segments. The federal risk adjustment program uses health status adjustment or health status risk scores to more equitably distribute payments and to disincentivize insurers from favoring healthier patients. So in general, insurers who have healthier members will pay money into the risk adjustment program. So that's shown in red. And insurers who have sicker members will receive money, which is shown in black. In 2019, 2020, and 2021, Matthew Thornton Health Plan is the only significant payer, meaning they generally have healthier enrollees compared to the other insurers. Matthew Thornton's payment did decrease from about 17 million in 2020 down to 10.7 million in 2021. Now, Celtic or Ambetter, they were a receiver of risk adjustment in 2019 and 2020, but as they've continued to gain enrollment into 2021, they're pretty much running neutral. They only had a $100,000 payment. And the last column in this table shows the 2020 numbers on a PMPM basis. Here we're showing loss ratio information for 2021 in the individual market. So this information is coming from the data used in the federal MLR reports, but this is not meant to replicate the federal MLR rebate calculation. This is just looking at 1 year of data from those reports without any of the adjustments that are made in the MLR rebate formula. So we looked at, in the individual market, we looked at this information two ways. The chart on the left has not been adjusted to reflect the rebate payments that are based on the 2021 forms, while the chart on the right has been adjusted to reflect those rebate payments, the MLR rebate payments. Federal MLR rebate payments from 2021 forms, they're paid out in 2022, and they're calculated based on experience from the prior 3 years. So in this case, it would be 2019, 2020, and 2021. So due to the federal MLR rebates formula use of 3 years of data, insurers' experience from prior years continue to impact the future year's calculation of MLR rebate. The risk margin in 2021 was 6% prior to accounting for MLR rebates, but after accounting for these rebates, the risk margin has decreased to 1%. Now, when you go back to last year's report and look at the same information from 2020, the risk margin was 10% prior to the MLR rebate payments and 2% after accounting for those payments. So these results indicate that the federal MLR rebate policy does appear to be effective in lowering insurers' risk margins. Now, when you look at the rebates themselves in 2021, as a percentage of premium, they represented about 5% of premium in 2021. So this is lower than what we saw last year. In 2020, those rebate payments that were made back to consumers represented 7.7% of premium, or $24.6 million. And then the other key takeaway from this slide is once you account for the MLR rebates, so the pie chart on the right, you can see that 78% of premium in this segment in 2021 was paid toward medical and pharmacy claims. Turning to the small group market, the total amount distributed from the risk adjustment program was $6.3 million in 2021, which is a slight increase from what we saw the prior year. of $4.7 million. In 2021, Tufts Health Freedom Plan and Harvard Pilgrim Healthcare of New England continued to be the largest payers, while Harvard Pilgrim Insurance Company and Matthew Thornton Health Plan continued to receive most of the risk adjustment payments. So this again suggests that Tufts Health Freedom Plan and Harvard Pilgrim Healthcare generally enroll healthier risk in its market, while Harvard Pilgrim Insurance and Matthew Thornton generally enroll the less healthy enrollees. This last data slide looks at loss ratios in the group market, so small group and then large group fully insured for 2021. And in both these pie charts, we've adjusted the results to account for federal MLR rebates. Federal MLR rebates on a percentage of premium basis is smaller in these segments than what we saw in the individual market segment from 2 slides ago. So in the small group market, about 1% of premium was paid back in MLR rebates in 2021, and similarly in the large group market, about 1%. The risk margin, or the contribution to surplus, which is shown the purple slice of the pie, and the small group market was 2% in 2021, which is lower than what we saw last year. It was 4% last year. And on the large group side, excluding the FEP population, that risk margin is currently running at 2%, and last year it was higher at 5%. So one other thing to point out, the red part of this pie chart represents federal and state taxes. So during this time frame, the ACA insurer tax was in place back in 2020. So when you look at these results in 2020, you'll see a higher portion of premium going towards taxes as a result of the ACA insurance tax, but then that was repealed in 2021. So the red piece of the pie is going to be lower than what you've seen in the prior year. After accounting for MLR rebates, 83% of premium was paid toward medical and pharmacy claims in the small group market, and 85% in the large group market was paid toward medical and pharmacy claims. All right. So there's a ton of information presented, but this is how we boiled it down to some key findings from everything we've looked at this in this report cycle. So first off, the individual market, as we mentioned several times, we saw those significant increases in enrollment in 2021, but that continued into the end of 2021 and into 2022. So due to several factors, first off being the start of the state-based reinsurance program in 2021, which saw significant premium reductions for that segment. But then we also had the additional subsidies due to ARPA coming into play in early to mid 2021 continuing. And also the extended enrollment period in 2021 appears to have brought in more people into the segment that year as well. The small group market, on the other hand, they have continued to see some slow but steady declines, but the rate of decrease does seem to have slowed down to what we saw a couple years ago. Now, when we look overall at the New Hampshire commercial situs enrollment, in the most recent couple years, that the overall enrollment is fairly stable, even though we're seeing shifts when you look among the segments, but in total, it's fairly stable. But at the same time, we've seen that significant growth in the Medicaid population. 2021 claim trends were significantly higher than what we saw in 2020, but that is driven by the low utilization levels that occurred in 2020 as a result of COVID-19. When we look at the 2-year average annualized trends, those 2-year trends are lower than what we've seen prior to the pandemic. Pharmacy trends have increased significantly this year, and it does appear to be driven by specialty pharmacy. And lastly, when we look at the federal MLR rebates in 2021 and back to 2020, they're resulting in lower risk margins for the insurers. than there otherwise would have been if there wasn't these rebates, these MLR rebates in place. So that is everything I wanted to cover today. The full preliminary annual hearing report is available on the NHID's website. So that provides even more context and additional information beyond what I presented. And on behalf of Gorman Actuarial, we would like to thank the NHID staff for all your support, and also to all the New Hampshire insurers, because they're the ones providing us all the data. So thank you to all the insurers in New Hampshire. And now we have time for some questions. So I think we're taking questions two ways. If you're in the audience, you're welcome to raise your hand and ask a question. And I think for those online, you can submit a question through the chat feature, I believe. Okay, and Dawn is monitoring that and can ask those questions.
Why don't we start with the live audience first? If anyone has any questions, we can do those. And then move on to the ones from the virtual.
And Paula Minahan from the Hospital Association. A couple of things. One, I think it would be interesting, and I think this is probably more for the department, but to take our entire population and kind of see where the enrollment fluctuations are, because we were just chatting here. We're curious about the uninsured and then then the small group and individual, where they all went. And we think some of them actually went to Medicaid. And I think you were kind of getting to that at one of your slides. So I think it would just be interesting maybe for the future to take our entire population. The other thing that we're seeing is a big shift from Medicare kind of traditional to Medicare Advantage. And I know that's probably not the purview of this review, and I appreciate that, but I think this is more for the department, maybe just to look at our population, because it has some implications, and certainly as our population ages. The other thing I was going to suggest is under looking at inpatient and emergency room. When you see the increase in PM, I think I'm trying to remember where that is. The other thing I think that would be interesting is if you could look at DRGs or case mix indices, because we know our experience with our members is that the folks that did come in 2021 were much sicker, and they stayed longer, and they are much sicker because of that decrease in utilization in 2020. They delayed care, as we all know, and unfortunately some that delayed care ended up being much sicker and needing more services. So just an observation, and I don't know if that's actually available, but I think it might be through DRGs, I think, and the case mix index.
Yeah, I mean, we don't collect that through the annual hearing process, but I know that information is available, like in the APCD perhaps, or other sources. Yeah, I guess to that point, I mean, you can see the inpatient facility trend here on a PM basis is fairly high at 17%, but the utilization itself is not jumping up quite as much. So I think that would speak to probably what you guys are seeing.
Thank you.
Okay, seeing no other questions from the live audience, I did want to bring up one question that was posed about, kind of fits in with what Paula was saying about the shift of memberships to Medicaid population. It was pointed out that the Medicaid figures 2021, probably around about 16%. I think it's slide 21, Jen.
Oh, am I kidding?
Slide 20.
Is that it?
Yeah.
Okay.
So it's true. The Medicaid percentage is probably in 2021, probably was around that 16% mark. We show a different slide at the beginning of the presentation that comes from a different source. It's from U.S. Census Bureau, ACS. It's a one-year survey estimate. And we show that the Medicaid-only population is about 10%, but there's also people that have dual Medicare and Medicaid. And there's also, the government breaks it out into like 14 different categories. And there's also members that they capture that are in multiple coverage categories. So I agree with the comment that was made on the chat. Medicaid figures are actually close to 16%, which we show here. But what we're doing is we're showing what the U.S. Census Bureau is reporting for Medicaid only, and then those other categories. So I hope that clears up that question.
Yeah, and I guess most of our report and our focus is on the commercial population that we collect all that information from the insurer. So I feel like the point of this slide is just to try to give the readers just an overview of what, where people are getting their coverage in New Hampshire. And I think to Don's point, this isn't going to line up exactly with the actual enrollment figures we're getting at the state level. And some of it's because of these other coverage combinations, and some of it is just due to the fact that it's survey data. So the point of this is just to still give readers an overall sense of how many people are we talking about and where are they getting their coverage.
That was the only question that was asked. Good job.
Great. All right. Well, thank you.
Take a break now. We're gonna take a break until 10:25. We can get back in our seats. That way we can get right going at 10:30 with our panel. Thanks again. That's always so helpful. If after today you find that you have questions that you wish to ask, just forward them to my team. We'll get them to the team at Gorman and coordinate so that we get you the right answer in a timely fashion. I'm happy to do that. And always, as always.
Thank you.